you have to be registered and you have to pay the fee. This is for attendings, obviously. We will send out a pre and post survey questionnaire. This is required from the AAFP to get your CME credit. We'll send them out within a couple of days of the conference, probably early next week. Because of our staffing limitations, we will close the window on CME request on February 9th. Thanks for understanding. We're stretched pretty thin here, so that's why we have to have kind of a tight window on that. We will also be posting recordings of the talks on our residency website at the end of this. Again, they should be up within a couple of days. This year, we'll be recording each talk individually, so it'll be easier to access the talks if you want to look at them afterwards. In addition, we'll send out slide decks of the different talks, and our only ask on that is that you use them for your own teaching. Please acknowledge the speaker's work who you're using for that. And lastly, I want you to think about this. There's a little bit of discussion about potentially doing a hybrid conference next year, assuming we keep doing this. And that would be potentially having in-person as well as the virtual option for next year. So when you fill out your survey, let us know what you think about that as a possibility. Okay, so we are right on schedule to start with our first talk, and I'm very proud to say our first speaker today will be Dr. Marianne or May Dakkak, class of 2015. Dr. Dakkak completed her residency in obstetrics at the Santa Clara program shortly after graduating. Currently, Dr. Dakkak is the Associate Program Director at Boston Medical Center Family Medicine Residency, where she's an assistant professor. She's also the Associate Director of the Maternal Child Health program there at BU. She works in Boston doing full spectrum family medicine, surgical obstetrics, hospital medicine. She describes herself as a jack of all trades, and anyone who knows May would describe her as well as a jack of all trades. Dr. Dakkak has also done quite a bit of writing about the practice of medicine, and I remember a terrific article she wrote a couple of years ago about her experiences caring for patients during COVID that was published in the AFP Journal. Passions include reproductive health, pregnancy care, healthcare disparities, LGBTQ care, and I would say just being passionate is a good way to describe Dr. Dakkak. So Dr. Dakkak will start today's talk, a series of talks talking with us about first trimester bleeding. I'm going to stop share, and Dr. Dakkak, you can go ahead and start sharing now.
So while I get my presentation up, I just want to say that this feels like a wedding, because every person who comes on, I'm like, I love them. I love them. I love them. And I see Danny Tobe is on, and I still do say the same thing about my patients. But so I'm very excited to see many of the names on the screen. It just makes me happy. So I'm going to talk about a topic that's very near and dear to my heart. First trimester bleeding. This is just my intro slide. This is the topic. This is who I am. I'm out in Boston. We have a guest room if you ever need a place to stay. Let me go forward. Oh, if it'll go forward. Okay, there we go. So this is the outline. First, we're going to talk about the epidemiology. We're going to talk about the exam and etiologies. And then we're going to talk about evidence of the risks of bleeding, what makes bleeding scary, what makes bleeding less scary. We're going to talk about algorithms for management, and then inclusion. So this is just from a kind of bird's eye view. 25 to 30% of our pregnant patients will experience bleeding in the first trimester. So it is very, very common. The timing can vary, and this gets a little bit into the weeds, but I did find it interesting. So this was a study that was just done in the first 8 weeks. Over 2,000 pregnant patients were followed. So very few bled right away. 14.6% of the 30% bled between the 4th and 6th weeks. And the majority of the bleeding was between 6 and 8. In the same study of the people who had miscarriages, it followed a fairly similar trajectory. And then for those who had live births, there was significantly less bleeding in the 6 to 8 period. It didn't continue on that trajectory. So this is just overall, if your patients come in with this, we don't want to normalize something that's scary, but reassuring them that this is fairly common and it doesn't mean something bad is necessarily going to happen. What are people afraid of? They're afraid of miscarriage. 1/3 of all beta HCG detected pregnancies end with pregnancy loss. 10% of ultrasound confirmed pregnancies end with pregnancy loss. Ectopic is rare, but there, and we have to be aware of it in the back of our heads. 2% of pregnancies are ectopic. Looking at the more common and less dangerous etiologies of vaginal bleeding in pregnancy, they're more common in pregnancy. BV is more common in pregnancy than outside of pregnancy, related to the pH changes in pregnancy. 10 to 30%, it's a pretty wide range of pregnancies are affected by bacterial vaginosis. There was previously data that linked it to preterm delivery, and we were a little bit more aggressive about it, but is no longer associated with preterm delivery, although you should still treat if there are symptoms. Vaginal candidiasis is much more common in pregnancy due to changes in pH and increased glycogen production, which just changes the flora of the vagina. Trichomonas, which doesn't show a difference in pregnancy, is associated with low birth weight, preterm and premature rupture of membranes. Preterm birth, sorry, and premature rupture of membranes. And then this other, thing that people are afraid of because it can cause potentially bad things is the subchorionic hemorrhage hematoma that now, with our level of ultrasound, we're now able to see it, whereas maybe 20 years we weren't picking up on them. And it's the most common cause of bleeding in the late first trimester. And it's the most common cause of bleeding between 10 and 20 weeks. So I'm not in, you can tell me if I'm allowed to ask questions or not, because I wasn't sure if people were allowed to respond. But this is just a case intro.
I think if people want to respond in their chat box, they're welcome to do that. Let's do it that way for now.
Okay, perfect. And then after a few seconds, you guys can read me what the chat box says, because I don't have it open. A 38-year-old G3P2 at 5 weeks gestation calls in due to vaginal bleeding. What do you want to know and what do you want to do? And just put things out there. We're going to get through it. So I'll give people about 2 minutes, a minute and a half to reply. Just put things in the chat.
So questions we're seeing is how much bleeding are they having? What are the symptoms they're having? Did they have a positive HCG? Have they already had an ultrasound? Any history of ectopic or IUDs? Are they having pain with it? I think we're all pretty familiar with most of the questions that we would ask at this point.
Yeah, so let's answer some of those. So you're asking the right questions. Any other symptoms? Specifically in this patient, no, she hasn't had an HCG or an ultrasound. She's not having pain. She's having only bleeding. IUD was removed about 6 weeks prior to getting pregnant. No history of ectopic. And how much? It's enough to have red blood, soak through her panties and her pants. So she was sitting at work and woke up, or not woke up, and stood up and kind of was sitting in a little pool of blood. So exam, and this is maybe, in this case, I think we're worried of a bigger bleed than what would be caused by vaginitis. But with light bleeding, it can often be due from vaginal causes. These are 2 pictures. One is just the pregnant ectropion. So you can get really friable cervices in pregnancy, even outside of having a vaginitis or vaginosis. This is a polyp on the top right. One of my attendings here may remember that I very ballsfully removed a polyp in pregnancy and caused a lot of bleeding. I've learned now to use silver nitrate. But polyps can bleed quite a bit in pregnancy and can also recur in pregnancy. So taking it out doesn't always make it go away. Always assess for vaginal bleeding. It can give a patient a lot of hope if you actually find exactly where they're bleeding from. Get your vaginitis, vaginosis swabs, manual exam. And this is, pregnancy is very early. We don't know what's going on. Is there tenderness of the cervix? Is there tenderness in the adnexa or uterus? Is the size of the uterus appropriate? And then labs to get, especially if you have, more than just spotting, and this is an early pregnancy, is beta HCG plus minus progesterone. We'll talk about that in a little bit, and blood type with RH in case they need RhoGAM. And an ultrasound, of course, as somebody mentioned. So this is how I often teach residents about diagnostic, like differential diagnoses. What's the most common? And then what are the most dangerous things that you have to rule out? So the most common in pregnancy are postcoital bleeding. So in this early pregnancy like this, so there is fairly good evidence that this early at 5 weeks, you wouldn't have to. Some people may still do it, but there is no actual blood connection yet between mom and baby. The vessels have not formed yet. Yeah, so there's no evidence that in this early of pregnancy you would have to give RhoGAM. That said, if a patient was super nervous, you could give it, but I wouldn't routinely recommend it this early in gestation. So the most common are the postcoital bleeding, STIs, Candida BV, polyp. The potentially dangerous to the pregnant person, ectopic pregnancy, trophoblastic disease, cervical neoplasm. This is why on all of our checklists is checking to see if their PAPs are up to date. And then there's potentially dangerous to fetus, which are subchorionic hemorrhage, abnormal placentation, threatened miscarriage, and incomplete miscarriage. And many of these require an exam and lab tests and ultrasound to diagnose. So these are, we've all studied these. These are the laboratory tests that we often do in pregnancy. The first one is the beta HCG. We're very used to ordering this, especially in a 5-week gestation. Who knows what you're going to see in ultrasound? Very possibly nothing. So getting a beta HCG and trending it every 2 to 3 days, depending on the gestational age, getting a blood type, and deciding if the patient needs RhoGAM, depending on where in the first trimester they are having their bleed. After 10 weeks bleeding, there is a fairly structured placenta there at that point, and it would be recommended. Yeah. Yeah, exactly. Okay. Hi, Christine. And then progesterone, there is some evidence that a one-time level that shows less than 6 or 19 based on what lab you're using excludes a viable pregnancy. Sorry, I have the chat open, so I blocked my own slide, which is probably not smart. And then CBC to monitor heavy blood loss. If a patient is losing a lot of blood, I'm often shocked by how many people don't get CBC. So just get a CBC and add it there. So this case, we're going to go back to it. This is, again, this 38-year-old G3P2, 5 to 6 weeks gestation, vaginal bleeding. So she spotted for a day, had bright red blood, no immediate previous sexual activity, no history of STIs or abnormal pap smears, no history of GDM or hypertensive disease or fibroids. Her beta HCG that day is 512. 2 days later, it's up to 1100. She continues to have pink spotting on and off most days. So now what you want to do, and I think somebody already answered this, so I'll just jump to it, is you want an ultrasound. You want to see what's going on the inside. So this is a chart I refer to a lot. There's one from the New England Journal of Medicine, and there's one in the AAFP. And this is how we diagnose early pregnancy loss. So I think Vista has ultrasounds. I have an ultrasound with a vaginal probe at my site. And I think it's really I think it's really important in prenatal care to be able to have one just in case people come in with first trimester bleeding, to be able to assess how the embryo is growing and whether or not we think it's at risk of loss or has been lost already. And so I also use this when I get ED reports, because RED, and I don't know if it's the same out there, RED loves to do the ultrasound, not tell the patient anything, and then send them back to us. So oftentimes I'm the bearer of bad news, and I will just essentially bring this chart in with me to kind of show them, because as you can imagine, patients are often asking, well, why didn't they tell us there? And I have to tell them, well, sometimes they're not trained in understanding these charts, and that this is clearly a early pregnancy loss. So I'm not going to go into the data, but I'm putting this here so you guys can have it if you want to use it. So subchorionic hemorrhage. This is, I think we all hate these because there's really not much to do about them. So they come in grades, everything is graded now. It's small if it's 20% or less of the size of the gestational sac, medium if it's between 20 to 50, and large if it's over 50 to 66% of the gestational sac. Very interesting, and I thought very hopeful, first trimester subchorionic hemorrhages that do not persist into the second trimester have no correlation to antenatal outcomes for the mom or the baby after 20 weeks gestation. This includes gestational hypertension, preeclampsia, preterm birth. It does increase the risk of miscarriage in the setting of also having vaginal bleeding. So a subchorionic hemorrhage without vaginal bleeding does not increase the risk of pregnancy loss. I think there's conversation about abortion care going on. Okay, I'm gonna let that go educationally for everybody. So subchorionic hemorrhages can be very nerve-wracking for patients, but I do find this Green Journal article very reassuring for patients that generally speaking, they are okay, especially if they are small. A small subchorionic hemorrhage is only correlated with vaginal bleeding. Medium and large are associated with placental abruption and first trimester pregnancy loss. And large subchorionic hemorrhage, along with the abruption and first trimester pregnancy loss, is also associated with preterm delivery, which is also iatrogenic for reasons of induction. Okay, so imaging. So this patient didn't get an ultrasound right away. She has things to do and waited until she was 7 and 4. Patient reveals viable IUP consistent with dates, grade 2 subchorionic hemorrhage, normal cervical length. So this is more of an explanation of physiologic bleeding and why it kind of peaks between 6 to 8 weeks. So the corpus luteum supplies the progesterone until about weeks 6, and then it really starts to drop off at week 5 and is gone by week 9. And at the same time, it's transitioning to the placenta, which is just starting to build up, just starts at week 5 barely, and then really develops between 6 and 9. And the spiral arteries remodel at week 10, which then creates a higher oxygen environment in the placenta by week 13. So this causes a temporary drop in progesterone, which causes bleeding for a woman with her regular menses, and also can cause spotting, not heavy bleeding, but can cause spotting at this transition point of 5 to 8 weeks. This is what we call, placentation bleeding. They call it the luteal placenta shift bleeding. And it's explained physiologically with this, which I find sometimes useful to tell my patients, because I often see the corpus luteum or, the cyst when I'm doing their first ultrasound, and I'll be like, oh, there's your cyst. And they're like, oh, I have a cyst. And I'm like, no, this is a good cyst. This is doing the work it needs to do. and it should disappear. And then it disappears, and I'm like, if you have a tiny bit of bleeding, that's okay. But that is just important for us to understand when we're talking to patients about why this is fairly common. And okay, so what are the risks of bleeding? Oops, let me go back. That was not what I meant to do. Okay, so these are risks to the mom. So overall, first trimester bleeding was a significant predictor of antenatal complications. And as you can see from this chart, many of these are also linked with placentation issues or placenta issues. The only one, none of them by themselves was significant, but in congruence they were. So the data is not fabulous, but that is seemingly where that direction is going. The data on miscarriage are much more clear. So light bleeding and spotting are actually not correlated to pregnancy loss at all. Heavy bleeding, especially heavy bleeding with duration of 3 days, were significantly correlated to pregnancy loss. And these are your charts where here the bottom gray is no bleeding and what the levels were of pregnancy loss. The white squares and the black dots are spotting and light bleeding, and much higher up here you can see is the heavy bleeding circles. So heavy bleeding is definitely not what you want, but still it's not like 100% miscarriage. It's still fairly low. Painless bleeding was not correlated with pregnancy loss at all. Bleeding and pain, especially heavy bleeding, was significantly correlated to pregnancy loss. So bleeding alone, it seems to not be sufficient, but it's the cramping that goes along with it that is more indicative of possibly losing the pregnancy. So this is just looking at the timing. This was a prospective cohort of over 4,000 patients. All bleeding, as you can see, again, this is the luteal placental shift that's happening between 6 to 8 weeks. And then heavy bleeding doesn't necessarily follow that curve and kind of has a second peak after that shift. 24% of those with heavy bleeding experienced pregnancy loss. 11.6% with any bleeding had miscarriages compared to 10.9. Oh, sorry, without any bleeding had miscarriages compared to 10.9 who reported any bleeding. So light bleeding really doesn't affect pregnancy loss, which is good for our patients to know. Risks of bleeding, there's some more studies that are in references. Nausea. So patients in pregnancy, patients in the first trimester who have bleeding, who do not have nausea, have an increased risk of pregnancy loss, which I always ask my patients who are bleeding if they're nauseous, and I tell them nausea is great because that means your placenta is still attached and secreting hormones that are really bothering you. Subchorionic hemorrhages, if it persists into the second trimester, it's correlated with preterm delivery and abruption. Pain, again, bleeding with pain significantly increases the risk of pregnancy loss, and the amount of bleeding. Light bleeding, spotting is not associated with pregnancy loss at all. Miscarriages are as common with light bleeding as they are in patients with no first trimester bleeding. And then duration. Moderate to heavy bleeding over 3 days is more predictive of pregnancy loss than shorter duration. So maternal predictors of bleeding: fibroids, abnormally short or long cycles. For light bleeding, history of prior miscarriage or induced abortion, nulliparity, vaginitis, vaginosis. For predictors of heavy bleeding, smoking, alcohol use, and pre-existing diabetes. So this is from the AFP. This is their algorithm for management. So bleeding under 12 weeks gestation, you do a physical exam. Here, this is really looking at ectopics. If there are peritoneal signs or hemodynamic instability, resuscitate, consider surgery. If a non-obstetric cause is found, like vaginitis, vaginosis, go ahead and treat those. If you see on speculum exam that it's an incomplete abortion, treat as indicated. You can do expectant, medication management, vacuum assisted. And then if the patient is stable and there's no products of conception, perform your ultrasound, do your beta HCG, find the pregnancy. If it's viable, monitor. If it's non-viable, consider treatment. If it's ectopic, you have expectant methotrexate or surgery. And if you have a pregnancy of unknown location, yeah, you've just got to find where it is. And the most important part of this that I always tell residents is, if you knew you had something in the uterus and then it's not there, you don't have to follow the HCG to 0. But if you never knew if you had something in the uterus, but the HCG is dropping now, you have to follow that to 0. Okay, back to the case. The ultrasound reveals viable IUP, normal cervical length. And here I put, like, are you worried as this clinician? She continues to have spotting. What do you recommend? And this is, I think these are the hardest cases, is what we recommend in these cases. So there is no indication to trend progesterone. They recommend, if anything, just a one-time test, because there's actually no evidence anymore for using it, which brings us to this. Does McKenna or vaginal progesterone help? There's insufficient evidence outside of cervical shortening. Small studies with very small n's, because it's rare, support that in women with 3 or more miscarriages and first trimester bleeding, that vaginal progesterone can be helpful. But outside of cervical shortening, there's no evidence that progesterone is helpful. Does bed rest help? Actually, no. An SMFM review, I think 2 years ago, showed an increase in all preterm deliveries in patients prescribed any form of activity restriction. So it's actually not healthy for our patients and not healthy for their pregnancy to restrict them. What about pelvic rest? It's really only indicated in placenta previa prior to 12 weeks. There's no added benefit. Cerclage in just vaginal bleeding, there's no evidence to support it, only to be considered again for cervical shortening of history of preterm delivery. So it's sad to say that most of the management is what not to do, because none of these things actually work. How to support your patient: mental health, counseling, psychiatry if needed, more frequent visits, supporting leave. Talk about stigmas. Did somebody ask something? No, okay. I have a link here to an article that I wrote about the stigma against women, even in leadership positions, taking leave, and that workplaces really treat women differently after taking leave. And I'd like to just talk about those stigmas out loud, because I think a lot of patients feel them and they feel like they're alone in feeling them. But if they need that leave, they should have that leave. And then financial difficulties: assess housing, food, and financial insecurities, work with social work case managers to build support, because these patients are undergoing a lot of stress, even if we reassure them a dozen times, 100 times that their baby is still doing okay. So conclusions: most light bleeding is self-limited and not a risk to pregnancy. Locate and monitor the pregnancy. Heavy bleeding, especially in the setting of pain, is higher risk for pregnancy loss. Vaginal exam, cervical exam, including pap smear, can reveal non-pregnancy related causes of bleeding. And it's a lot of watchful waiting. Try not to over-medicalize it. We always want to do that, as it doesn't actually change outcomes. And don't do what I did and just remove a polyp in pregnancy because they bleed even more, and silver nitrate works better. In conclusion to this case, 38-week G3P2, moderate bleed at 5, 11, 15, 20, 24, and 30 weeks gestation, develops anemia, subchorionic hemorrhage becomes chronic abruption, stops working overnight shifts at 20 weeks, stops working outside of the home at 24 weeks, manages COVID resulting in vaccine clinics remotely, continues to have pink spotting on and off most days, induced at 37 weeks, gives birth at 37 weeks. And this monster will be 3 years old tomorrow. That's a great question. So there's actually, I didn't put it in here, but there's one of the articles actually shows what they showed the patient. And if it's just when you wipe or just like smear of pink or red on the underwear or pad, it's called light. And then it's not called moderate until it fills like half the pad. And then it's called heavy if it fills anything more. So the progesterone really is there's really only a great negative predictive value. It's if it's less than 6, it's a non-viable pregnancy. So there's no actual level that the patient can sit and be like, okay, this is fine.
Terrific. I don't want to cut you. Can I jump into some questions, May?
Yeah.
Great. So that was fantastic. Really learned a lot. Great way to start the morning. A lot of good questions coming up in the chat. I'm going to ask a couple of questions kind of inspired by what we're seeing in the chat here too, and then people can pipe in. We have about 5 minutes. We have 6 minutes for questions. So traditionally, I would say that any bleeding, traditionally I would say miscarriage rate for any pregnancy is 20 to 25%. But if we saw your data or one of your slides correctly, if you have a positive HCG, miscarriage rate is 1/3. Is that correct?
Yes.
So it's even higher than what I've been saying for years. So anybody positive pregnancy test, they basically have a 1 in 3 chance of eventually losing the pregnancy. Yes.
And this is with early HCG levels.
With early HCG levels. Okay.
Exactly. So these are, this was a great prospective study that worked with 4,000 patients that had them actually check their HCGs 2 weeks. They had them check their HCGs. And
Yes.
so when they had them check them at like 3 weeks, 4 weeks out, 1/3 of them miscarried. And most of our patients would never know that they had that.
Gotcha.
Because they would have they would just have a menses. And that's how much blood they would lose.
Right. So these were very, very early identified pregnancies, earlier than even most of our patients would even begin checking. They just happened because of the protocol they were following. They captured these pregnancies very early, and then 1/3 of these went on to finish or to miscarry. Gotcha. Okay, good. And then just to be really clear too, light bleeding, which you just clarified for us, we can safely reassure patients if they meet the light bleeding criteria, which is also a bit of a practice change for me. I always say bleeding is never good in pregnancy, but if it's really just staying light, we can look at people and say, yeah, it looks like it's okay. Let's just watch and wait. This doesn't really increase your risk of loss beyond the background risk.
Exactly. That's what they showed. It's the same huge study, over 4,000 patients, showed no increased risk in spotting or light. So even if it's getting on their pad or getting on their underwear, as long as it's still light and not filling up like half that middle pad, it's considered light. And it also didn't matter. It didn't matter whether it was brown or pink or red. Color didn't matter. Yeah.
Great. 2 more things, and then I'll just open it up real quick. So just subchorionic hematoma. You did a nice job talking about it, but could you just say how you talk to patients about a subchorionic hematoma and the implications?
Yes. So when I talk to patients about subchorionic hematomas, especially now that I've had one, I tell them that we just measure the size, and what we want to see is that it's shrinking. And if you have one and you're no longer bleeding, your risk actually becomes the baseline risk.
Okay.
If you have it and you're continuing to bleed and it's not shrinking, then we worry that it's going to become a chronic abruption. And then we'll just have to monitor with Q3 to 4 ultrasounds to make sure that it's not growing bigger. And even if it is growing bigger, we have to talk about what you'd want to do.
Okay, fantastic. And my last question, so does this RhoGAM, in England, they've been saying for a long time, no RhoGAM early on. Now we're seeing agencies here saying the same thing. So no RhoGAM before what weeks for bleeding in pregnancy?
So the recommendations, I think there in California, they're sticking to 12. Here I've seen it as early as 10, but not before 10 weeks.
Okay, so we can
There's
all
just there's no
safely,
placenta there to cause any issue.
great. So we can all safely just stop doing RhoGAM before 10 versus 12 weeks for any bleeding in pregnancy. Terrific. We have about 2 minutes if people, or 1 minute, if anybody wants to unmute and ask a question of Dr. Dakkak. Well, all right, well, the chat box is open. I hope May will stay on for at least a little while so she can address any other questions might come up. And we'll go ahead and move on. There's that long list of references.
Yep.
Great.
And
Thank you
that's
so
it.
much. That was great, May. Really appreciate it. Thank you so much. Wendy Dryden
Yeah,
saying
so
hi
I
to
think
you.
Wendy just asked, yes, so if you are pregnant, if you are bleeding and you have nausea, it is protective. If you have bleeding with no nausea, it is more predictive of pregnancy loss. And especially in this, I think we've all anecdotally seen it. If you are nauseous and become not nauseous and start bleeding, that is very predictive of pregnancy loss. So you want people. I know. I don't know, Wendy. That's a great question. The NIPT works after, well, I actually get a lot of mixed results after 9 weeks. I don't order it until after 10 weeks.
Okay.
So
just a 9.